welcome back to my channel. So today I'm going to be talking about antidepressants and anxiolytics, which are anti-anxiety medications. So I'm going to be talking a little bit about the history of them, and I'm going to be kind of critiquing the different types as well. And the reason why I'm doing both in the same video is because they are used so interchangeably. So you see many kind of antidepressant medications are also used for anxiety and vice versa, and some antidepressants can be very, very effective for anxiety. It's just that they've been marketed as an antidepressant and vice versa. So I'm going to be talking about both of them interchangeably. And there's several different kinds that I'm going to be talking about, some which we don't really see anymore, but that kind of existed some point in history. I've got some visual aids as well, which just goes to show how much time I have on my hands at the moment. But yes, okay, so I'm going to be starting with benzodiazepines, because these were kind of the first antidepressant, anti-anxiety medication that came along. So the first one was in 1954, and that was Librium. And then after that we had Valium, or diazepam, is what some people call it. That was in 1962. And then we had nitrazepam and lorazepam. So lots of people kind of associate benzodiazepines as being a street drug. They're not as readily prescribed anymore because they are so addictive. But I think you can still get a prescription for them. They're also used as an analgesic, so to relieve people with chronic pain conditions, that kind of thing. And they're also used when people are withdrawing from certain drugs or from alcohol, because they can help people prevent seizures and that kind of thing, and they can just bring a lot of comfort for people that are in those kind of situations. So there's 5 general effects that occur when people take benzodiazepines. So firstly, they're a hypnotic, which means they make you feel very sleepy. So a lot of people who have depression and anxiety obviously struggle to sleep, so they're kind of very helpful in that respect. They're a relaxant, which can really help people who are having racing thoughts because of their anxiety, who are pacing, who have that restlessness. As I've mentioned, they're an anti-seizure medication, which is really helpful for people who are withdrawing from alcohol and other drugs. They're a muscle relaxant, and they're also an amnesic, which means that they disrupt long-term and short-term memory, which is not necessarily a good thing. But then I guess if you are experiencing something incredibly traumatic, or you're going through a very, very difficult time, then I guess in some respects that might be helpful. So obviously, as I've mentioned, they're not as readily prescribed anymore, and that's because the sensation that they give can be quite addictive. So there is a lot of kind of association with the drug with dependence and abuse. People also can develop a physical tolerance towards benzos, so their body kind of gets used to them taking it, which can create a withdrawal syndrome when they stop using them. And similarly to alcohol, you can really cause some physical harm if you are physically dependent on them and then you abruptly kind of stop taking them. So it's really important that you seek medical advice and you taper very, very, very slowly. So the way benzos work is they bind to what's called GABA receptors in the brain. So GABA is what we call an inhibitory neurotransmitter, which basically means it has a quieting effect on the brain. So in some ways this can be obviously a very, very good thing for people who have that kind of racing thoughts, who cannot get out of their head. But it also can be a negative thing in terms of you have less of those kind of excitatory neurotransmitter activity, so you have less alertness, less memory, less coordination, that kind of thing, which can make things difficult if you're still going to work and you're still having to do things in your daily life. So there's that kind of negative. Also, what researchers have found is that there can be some paradoxical side effects with long-term use. So people can have outbursts of rage, they can have severe bouts of depression or anxiety after taking them for a long period of time, which is not what you would necessarily expect, but it's probably to do with the way that we become tolerant to them. And again, as I've mentioned, there is also a withdrawal syndrome that comes along with this drug. There was a study which was very, very interesting. It was only 18 participants, but I will put all the references below. There was a study which investigated the subjective experience of coming off benzodiazepines, and it's a really, really interesting read. Basically, over half of the participants described having paranoid or frightening thoughts, specifically paranoid thoughts of persecution, so feelings that people were going to harm them while they were withdrawing from benzos, which is really quite frightening. And the general consensus was that it was a very frightening experience. People had quite severe physical and mental effects. So you can understand why it's not really prescribed that much anymore. So moving on from benzos, so around kind of just after that time, 50s and 60s, so we had electroconvulsive therapy, ECT, was used then for very, very, very severe depression. We're talking people who could not get out of bed, could not physically move, who were completely incapacitated by the disorder. So ECT was used, which was very dangerous back then. They didn't use the sedatives that we have today. People were strapped down, they would break bones during that procedure. So it really, it can be very helpful and useful the way they do it today, but unfortunately back then it was quite harmful to people. So people had ECT for severe depression, and people also took antihistamines. Interestingly, there was a researcher called Kuhn who discovered that imipramine, which some people might recognise as a hay fever medication now, imipramine can be used for treating the physical effects of depression. So it helped, basically he discovered that it can help people get a really good night's sleep. It can help with that sensation of hopelessness, that heaviness, that malaise. It's also important to mention that back then the way that depression was thought of is very different to the way that we describe depression today, in that back then depression was defined as either endogenous or exogenous. So you had endogenous depression, which was depression originating from the body, so purely physical, which is obviously associated with fatigue, low appetite or too much appetite, pacing, restlessness, or just no movement at all, trouble talking, trouble sleeping, that kind of thing. So that was perceived to be endogenous depression, which was perceived to be a very severe disorder, and those were the kind of people who were given the ECT and who were given the imipramine. And then you also had exogenous depression and psychotic depression as well, which you don't really hear about nowadays. So exogenous depression was depression that's caused by external factors such as a bereavement or a breakup or a job loss, that kind of thing. So they used to treat different depressions differently, which is really interesting because we don't do that now. So we just kind of lump everyone into one depressive category, and everyone gets given SSRIs typically as the first course. But we'll talk more about them later. It's just interesting to mention that the drugs that were used then were kind of in accordance with how people defined depression back then. So as I mentioned, the antihistamines were prescribed, and they were prescribed as TCAs, which has got up here, which were tricyclic antidepressants. So these were good in treating the physical effects of depression. So they were painkillers, they helped with appetite, they helped with physical symptoms such as such as pain. And these were really critical because these were needed to replace the benzos, because everyone started panicking about benzo crisis, everyone's getting addicted, oh dear, what are we going to do? So they suddenly had to bring in another antidepressant, and they brought in TCAs as a way of having an antidepressant or an anti-anxiety medication that wasn't going to get people hooked. But as a negative, the TCAs are lethal in overdose, and you can also get some quite severe cardiotoxicity issues, and there are sexual issues as well. So it's, you know, really quite important that we try and not give people with severe depression something that they can potentially use to kill themselves. So that's probably not a positive for that one. But on the upside, there was a really good systematic review. Again, I'll put the references down below. It was really strong. It met what we call PRISMA guidelines, which are a regulatory body for systematic reviews, that found that benzos are actually significantly better tolerated than TCAs. So there is actually some positives for benzos as opposed to TCAs. They also found that there was no consistent evidence that TCAs were superior to benzos, and that was in the treatment of generalized anxiety disorder, phobias and depression. So that kind of evens the board, I guess, in a way, in terms of benzos and TCAs. There was also, at a similar time of TCAs being developed, MAOIs, monoamine oxidase inhibitors, came out, and they work in a similar way in terms of serotonin, norepinephrine, and I think they stimulate adrenaline as well. They're also prescribed for Parkinson's, interestingly, but these really led the way in terms of psychopharmacology. This really got people interested in developing new drugs. So they came out at a similar time. Again, there were some issues with them as well. So there was a condition called hypertensive crisis, which unfortunately happened to people who didn't manage their diet on this drug. So it was really, really important that people had to not eat and drink certain things, for instance, alcohol and certain cheeses, and otherwise it would cause an increase in blood pressure, and there would be some fatal cases from that as well. However, some say that the media completely blew things out of proportion, and that really people didn't have to make such drastic allowances. So I guess kind of read your papers and make your own decision about that. So moving on to SSRIs. So these are selective serotonin reuptake inhibitors. If you know someone who has been prescribed an antidepressant, 9 times out of 10 it will be an SSRI. So they received FDA approval in 1987, and in 1988 the most commonly known SSRI, Prozac, became the most prescribed antidepressant worldwide. So I'm going to talk very briefly about how SSRIs work. So selective serotonin reuptake inhibitors. So basically, if you imagine that you have neurons in the brain transmitting neurotransmitters, basically you have some receptors on the end that basically absorb excess neurotransmitter that is left in what we call the synaptic cleft. So they absorb that. So basically what SSRIs do is they block these receptors so that you have this excess serotonin left in the synaptic cleft, and then this becomes absorbed into the next neuron and transported around the brain. So basically you are processing more serotonin in the brain, and this was a theory originating by 2 Russian pharmacologists who basically proposed that increasing serotonin will increase people's ability to feel good. And following that, we've had a lot of obviously lay media coming out and kind of perpetuating that kind of belief that depression is caused by biochemistry of the brain and that kind of thing. And the effects of the drug, it has kind of emotional blunting effect. It kind of has a little bit of a numbing effect as well, so it kind of can blunt those kind of severe emotional reactions to certain situations and can really get people through some traumatic experiences in that respect. So there is a lot of positive research out there promoting the effects of these antidepressants. I think one thing I will say is when you're looking at the papers, is look at who has published the paper and whether they would have a conflict of interest. If you see that it is being written by a pharmaceutical company, then it kind of makes you wonder what they were trying to achieve in doing that research, and whether there are any kind of biases in that research as well. So it was labelled as an antidepressant, but there's actually no research to say that it's any more effective in treating depression than treating anxiety. So there's some theories that say that it was labelled an antidepressant because at the time benzos were still being used quite regularly for anxiety. So there was a bit of a gap in the market. But just so you're aware, the research is that they're no more effective in treating either kind of disorder, but they are more commonly prescribed for depression than anxiety, and that's obviously because they're labelled antidepressant. There's also, I will say as well, there is a lot of research that's done on animals, which some would say isn't really that applicable to humans. You can't really generalise it to humans. For instance, they found that giving rats SSRIs increases escape behaviour for rats who have what's called learned helplessness. They've just given up. So there's that kind of thing, which I guess kind of works well in terms of positive for the drug, but it's whether or not you believe that kind of research can be generalised to humans. It does have some side effects. It can cause most commonly nausea, vomiting and insomnia, but on the positive there's no real risk there of addiction. So some people say that this was kind of the industry's compromise for after the benzo crisis. So it's really hard to get addicted to it. You don't get that really positive kind of warmth that you would get when you take benzodiazepines. However, you do get a physical tolerance to it, and there is a withdrawal syndrome, which some say can be almost as bad as the withdrawal from benzodiazepines. So there is some common kind of things that go along with this withdrawal. You have dizziness, irritability, agitation, sometimes you get a tremor, and that is seen within 20 to 50% of people who take SSRIs. There's also a real challenge in getting people off SSRIs. People tend to get a prescription and then they just keep on re-prescribing, and there's no real kind of plan in place for people coming off these drugs. So people can stay on them for many, many years, which I guess is okay, but when it comes to coming off, you're more likely to see some of these physical withdrawal effects and emotional withdrawal effects as well, because obviously your brain is so used to that serotonin. So when that's taken away, your brain has to take a little while to catch up, to get back to its normal self. What I will say as well is that apparently 80%, up to 80% of the body's serotonin is in the gut. So it's not just a neurotransmitter in the brain, a neurohormone, it's also a hormone in the rest of the body. So this is why common side effects are nausea, vomiting, that kind of thing, because you are disrupting what's going on in your gut, in your digestive system, and the rest of your body as well. But of course, in some instances, it's completely worth it if you're really suffering with your mental health. So this was kind of, as I say, this was developed, it had FDA approval 1987, and we saw prozac. You also hear of there is come on to sertraline, and fluoxetine is another name for prozac, and citalopram as well. So when it was first kind of approved of, there wasn't so many prescriptions, and then within the last 2 decades it's just absolutely boomed. So I don't know the statistics on it, but the amount of antidepressant prescriptions is absolutely massive. And one of the reasons for this is the media, but it's also because of the newer editions of the DSM, the Diagnostic Statistical Manual, basically enabled these kind of easy symptom checklists for clinicians, but also for medical professionals who are at a lower level, which basically means that people can diagnose depression very readily and prescribe very readily, which has kind of created this mass kind of prescribing of antidepressants, which I guess in some ways it's good for people that really need it, but there are some psychologists and some researchers who say that we are over pathologizing normal sadness. So that's just about everything that I wanted to say about SSRIs. I've also put this up here as a reminder because I wanted to talk about NMDA receptor antagonists such as ketamine, because ketamine, which is commonly known as a street drug, is starting to be used as an antidepressant in America. So they have ketamine clinics, and it might be starting to be used in the UK soon, who knows. So what they do with things like ketamine and psilocybin, they're doing studies on that as well, so magic mushrooms, is they use a microdosing technique. So you don't actually get the high that people associate with these kind of drugs. It's very, very subtle. But I think the theory behind it is that having that kind of pseudo hallucinogenic calm experience can help people reconfigure the way that they've been thinking about their lives and things that have been going on around them. So some really interesting findings from some of the research that's been going on about that. Some successes, although some say that after people have had the microdosing and have had the prescription and it's been over, that their depression returns, unfortunately. But that's, it's all still very new and very exciting, so hopefully there'll be some more on that to come. So yes, that's just about everything that I wanted to talk about. As always, if I've said anything you're not sure about, if you think I've made any mistakes, please let me know in the comments. And yes, thank you.